So today's episode, we had Dr. Kerin Orbuch on. I was so impressed with her. She's an OBGYN down in Los Angeles, and her specialty is endometriosis.
And she really seems to have solved the problem here. She has this treatment plan that is all-encompassing. She does perhaps focus on teenage patients, but she'll see any patient. And I'm, like you, very, very impressed with how she's dealing with this. She's an incredibly talented and trained surgeon and looks at this as a surgical disease primarily.
And she trained with all your surgical besties.
She did. That was what was so exciting for me, because she's had, in my mind, the perfect training.
Yeah.
So, enjoy the show. But what do I know? I'm just a vagina doctor. Dr. Kerin Orbuch, welcome to the Vagina Doctor podcast. It's really great to have you here, but to be honest, I knew nothing about you 2 months ago. And Kerin first talked to you or heard of you through Instagram, and then watched the documentary that you put together about endometriosis. And then there was a connection between one of your patients and who Kerin knew. In fact, the patient's mother was a very, very close friend of Kerin. And so I thought, finally, there's somebody that I can refer endometriosis patients to, somebody who really knows what they're doing. I just became more impressed, though, and more excited when I read your CV and I saw the connections that you were probably unaware of, and I became aware of the people you trained with. And I don't want to go through your entire educational experience. We could take all day to talk about that. But particularly a fellowship in MIS or minimally invasive surgery with two kings, leaders in the field, Harry Rich and C.Y. Liu, both of whom I know very well, worked closely with over the years. And from about 95 to 2005, we traveled together. We were all over the world together, operating, just having a blast. But so incredibly rewarding for me. And so, I think you were so lucky to be able to train with them, but probably more fortunate for them that they had you to train. So really exciting, and clearly I see the path that you've taken has been tremendous. So.
Yeah, I love that you know Harry Rich and C.Y. Liu. I mean, for me, being able to train with these giants in the field,
yeah.
But more than giants, it was what meant so much to me, not only learning their technique. I was pretty much their last fellows in both of their careers.
Yeah.
So not only did they have technical expertise, but they were like father figures, mentors to me in every way. So what was equally important was sitting with Dr. Liu at lunch and just understanding his wisdom about me being a parent, and all the way up to technique and drive and what I could accomplish professionally. So they are both still, I feel like the luckiest person in the world to have trained with them. Like the luckiest. I just, every moment of that training was like, wow.
Yeah.
Amazing. Right. Yeah. And so I guess what got me here in the first place, when I think back, it was interesting. I didn't have the reflection until I sat down to write my book, Beating Endo, How to Reclaim Your Life from Endometriosis. And it was a work in progress in my brain for 10 years before I committed to actually writing it. And when I sat down to write it, and one of the introductory chapters was like, why did I do what I do? Like, what led me to be passionate about endo, which I'm so passionate about. And I realized so much of my life paths have led me to where I'm at. And it's not a coincidence. It's from playing sports, lots of hand-eye coordination. I'm like a, crazy athlete, and playing video games as a kid with hand-eye coordination. And then you mentioned my dad, who passed away in, I think it was February of this year.
Oh, wow.
He was really instrumental he was a prolific cardiologist. He published over 100 chapters, textbook, journal articles, like, medicine was in the air he breathed. His patients loved him, and him taking me to the hospitals and watching what an impact he had, like all of it was very formative into me wanting to be a doctor. But I think what's made me who I am is just the way that my brain thinks. I'm a really outside the box thinker. I don't take anything face value. And when something is taught to me, I think about how do we tackle a problem from many different areas. In the field of endometriosis, nothing was being tackled when I got into it surgically. It was surgically, but no one was actually even thinking about the disease. Like, really, what is endo? How do you think about the disease? And I look at it actually from an inflammatory standpoint, which is what it is, but no one was looking at it in that way. And it's interesting because I'm part of this surgical organization, AGL, and I'm very active. I'm on their foundation board, and I was like the head of the endometriosis special interest group. But I'm like, it's not that I'm a free spirit. I am a free spirit, but I'm not like, I don't fit the mold of being a doctor in terms of like, memorize, take this, spit it back out, continue to do things the way for the rest of your career. And I think something that CY said to me, we were taking, I think, the 4-5 train back up from downtown after operating all day. And he said to me, if you're doing the same thing today that you did a year ago, stop doing what you're doing. So that's what I mean. Like, those lunches with him were as important as the technique that he taught me in the operating room. And I thought that was so fascinating. And it really made me think, how do I do my surgeries? What new information am I utilizing to change, to evolve what I'm doing, and never doing the same thing over and over and over again? And I think that all of those elements, from the video games to the sports to my dad to my mentors to just really being a thinker and challenging norms. And I mean, I got that from Harry. Dr. Rich challenged every, he was like a renegade in the field. And I feel so lucky to have had that mentorship and leadership in my training. And I think coupled with all of that, that's really what's made me who I am. And also, I'm a health junkie. And so approaching endo from an East meets West point of view, I meditate, I do yoga, mindfulness, I'm like a seeker. And I think approaching all of that with all those other elements along the way is so formative in what I'm doing. And I'm excited to see what will be a year from now. I don't know.
Yeah, it seems like your approach to endometriosis and patients that come to you is very unique from what other things I've seen. And I want you to kind of go into that. A patient comes to you, a young girl, let's just say adolescent or teen, and how do you go about that process?
So the first thing I do, which is very undoctor-like, is I listen and I don't interrupt my patients. And so actually the first thing that I do is I get all of their records and I read through everything before I see them. That's very undoctor-like. I've yet to meet a doctor who does that. And so I know all about them before they walk in the door. And then when they sit down, I say something along the lines of, is like, I have a sense of what brings you to my office, but I want to hear it in your words. Start way at the beginning. Don't leave anything out, and bring me to today. So this is like the first time an endo patient has actually been listened to.
Right.
And I learned that from both Dr. Rich and Dr. Lou, is to listen to the patient. and for my dad as well, but the two of them, because I was working with them constantly.
Mm-hmm.
And I listen to what they say based on reading the records, listening. Then I do an exam. Obviously, if it's a teenager, they're not sexually active, the exam is limited to what is appropriate. But just by the words that they use to describe their symptoms and their pain, as well as honestly how they're sitting in my office or on a virtual platform,
Mm-hmm.
their body habitus, are they hunched forward, the rapidity of their speech, there's so much. Like I wanted to be a psychiatrist, but I love surgery. So the mind to me is fascinating. So I put it all together after I've listened to them. And then I ask them a whole slew of questions, because a lot of patients are dissociated from their pain because they've been living in it for so long. And
Right.
doctors tell them there's nothing wrong with them because endo isn't in general picked up on imaging.
Mm-hmm.
It's a surgical diagnosis. So they're usually being told, oh, there's nothing wrong with you. Period pain's just bad and it's normal. Like, and so I approach treating every patient individually. I don't have like a formula. You got to do da 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 da.
Right.
Based on the records, listening to them, and their physical exam allows me to put together a multidisciplinary approach. And even if endo is what I think like one of their pain generators, you have to understand that endo, and my specialty is our teens and 20s, although I treat women in their 50s and 60s also. In general, in the US, there's a diagnostic delay of almost a decade, seeing 8 physicians prior to even getting to me.
Which is crazy.
Which is crazy. So let's just even say the teen is lucky and had 6 months of debilitating pain. Okay. 6 months of curling up in a ball, like a fetal position on the sofa in the middle of the day, in their bed at night. Usually they have gut issues, they're constipated or have diarrhea, they're like straining, so their pelvic floor is starting to tighten. They've seen the pediatrician, they've seen the mom's gynecologist. All of what gynecologists know about endo is disproven and outdated by 20, 30 years. Our American College of OBGYN guidelines are woefully outdated and inadequate. They're roughly 2010 guidelines that have been reaffirmed, which is scary. Anyways, they're so outdated. So the gynecologists typically tell the teen, there's no way you have endometriosis because you're too young, which is wrong. So there's already the teen is like, wait a minute, is this in my head? Why can't I go to school? I'm in pain. So by the time a teen even gets to me, even if they have 6 months of pain, we have to talk about why I think it's endo. We have to talk about, getting them into pelvic floor PT because their muscles are already tight from straining. And very often they have gut issues 2 years before even they start their period. We have to talk about rehabbing the gut because endo itself, these lesions are pro-inflammatory, setting off these interleukins, which are inflammatory mediators throughout the entire body. So we have to talk about rehabbing the gut, testing for like leak, to use a colloquial term like leaky gut or, dysbiosis, small intestinal bacterial overgrowth, rehabbing what they're eating. And I was talking to them about mind, body, meditation. We always talk about the anxiety, the depression. And I'm approaching them from a holistic, multidisciplinary approach. And I try and explain to them that endo is like a domino. It's like the first domino that's knocking down, like the tight muscle domino, knocking down, let's say the gut, like causing gut dysbiosis, and then maybe worsening anxiety or causing anxiety. So I like to work backwards. And then once people have made some headway on undoing some of the coexisting pain generators that happen because of endo, that's precisely when I do my surgery. And then they continue all of that multimodal approach after surgery. That's the way to beat endo. It works.
Now,
it totally works.
Okay, so that's something that it does work. So, but do some people go, no, I don't want to do all that? Do they fight you on it? Or are they pretty much like, all right, I'll do it. I'll do anything you say.
So
or they just want surgery. Are they like, no, I'm good with my diet. No.
So I usually say the following. I say, my surgery is not fixing tight muscles. My surgery is not fixing the gut issues. My surgery fixes the endo, which is causing all of this stuff. And I think this is what really works for the patients. I say, I could be doing 3 times as many surgeries a year, meeting you, booking you in 2 weeks for surgery. I said, I have a kid in an Ivy League. It's very expensive to pay for her college. I have another daughter who's about to start college. If I was financially incentivized, I would just be operating and operating, and I would do 3 times as many surgeries, but it's not the right approach.
Right.
So once I say that to them, I think they realize, and then I say to them, I have endo, my daughter has endo, and I implemented for my daughter exactly what I'm recommending to you. So why would I do something different for my daughter than I would for you? Once I explain all of that, then they buy in.
Yeah.
To it. I'm not looking to buy in and drink a Kool-Aid. It works.
Yeah. Yeah.
And then I say to them, I promise by the time we're done doing this multimodal approach, my patients are better between 30 to 70% better. Most of them are 70% better. So if I operated on you tomorrow, you're going to say, hey, Dr. Orbuch, you're the suckiest surgeon. I'm only 30% better. Are you at that point going to start doing all of this stuff when you're in the healing phase? No one is. They're going to start shopping around for another surgeon, then another surgeon, then another surgeon, because a lot of the pains are coming secondary to the endo. So I think once they realize that I did this for my daughter, and I tell them like different articles that she's written, and I'm like, this is what I did for myself. Then I said, I promise, let's do our follow-up in 4 weeks to 6 weeks. I said, if you want, let's book a surgery in 3 months or whatever I think the appropriate time frame is. But I said, I promise before we get to surgery, you're going to say, now I understand why. And every patient gets to that point.
That's fantastic.
Yeah. And I say to them, listen, if you want me to operate on you in like 2 weeks, I'll do it. I think it's the wrong thing to do. If you really want it, I will do it. And there are some times where patients don't have the time because they're moving out of state, they're moving out of country. A partner's having a big surgery that they're going to have to be primary caregivers for. Their insurance is changing. There's all different sorts of reasons. Those are the people who take even longer to get better. The more prehab you do, honestly, your overall time to getting better is shorter.
That's great.
So that's pretty much what I say.
I understand all of what you're saying, and I really want to emphasize a couple of things. And I'd written them down before we had this conversation, but I'm just glad you've taken the words out of my mouth, so to speak. And number one is listening, and that happens. It's not just endo; it's giving patients the importance to be able to really explain to you. And I also love the fact that you get the records ahead of time, because my office is so upset with me because I'm absolutely super compulsive about getting patients' records before I see them. And I said, if we don't have those a few days, actually I was going to the extent of at least a week before procedures, I don't want to see the patient. I just want to get that first because I want to be prepared for all of that. The other thing that I'd like to, I know what you think about this already, but it needs to be said again. Harry and CY taught you straight stick laparoscopy and excision of endometriosis, not vaporizing with the lasers or monopolar or bipolar RF. Excising that, and that's what Harry taught me that too, and it doesn't work otherwise. And I'm embarrassed to say that gynecologists are generally not very good surgeons. They do, because their focus is generally OBGYN and obstetrics. They do great C-sections, but when it comes the knowledge of anatomy, familiarity with anatomy is not where it should be, in my opinion. And we can look back to the training of OBGYNs that there just is not enough surgical training in a residency program. So you did the right thing of having that fellowship training, of really becoming a great surgeon doing this. And for me, it was watching these guys, watching their videos, being with them, talking to them, going on the conferences for that extended period of time, because it is, I mean, just being around the people that you train with is, we learn by osmosis to an extent also.
Yeah.
So it's, being prepared. And one final thing I want to emphasize is this absolute travesty of the delay in diagnosis. And it's only slightly less than what you're describing in patients who are seeking fertility. And so people that have laparoscopies earlier if they aren't able to conceive. And those patients are diagnosed with endo a little earlier and therefore treated more rapidly. All of those things are just really, I think is just, it's one of the areas where as physicians, we've really failed patients.
Yeah. Yeah. So, I have a bunch of comments about what you just said, is that even in my first week of fellowship, I remember both Doctors Rich and Lou were pointing out, basically in my first week of fellowship, I learned more appearances of endometriosis than I did in 4 years of OBGYN training plus 4 years of medical school. So I'm often saying I learned less in 8 years than I did in 1 week of my fellowship, because endo can be red and white and blue and brown, and in teens it's clear. So anyone who's operating on a teen, they don't know even what, they're these clear vesicles, you barely even see them. And so most generalists don't even know what endo looks like. So they're doing these surgeries that I love that Harry coined peakoscopies, because they're putting, the camera in for like literally 10 seconds, looking around. They don't even know what they're looking for. Then they're going to the waiting room. They're doing 6 or 7 of these cases a day. They're going to the waiting room, telling the family, I don't know why so-and-so has pain. I didn't see anything. And so I remember that happening over and over again in my residency. And I had a very good residency in New York City. And in that first week of fellowship, I'm like, oh my gosh, I feel so bad for all of those patients. I've seen all of this. Yeah. Those people had it and we're being told that they don't have anything. So it's part A, recognizing the various appearances, knowing the high yield areas, even when you don't see anything. CY taught me that. Where do you excise even when it looks normal? Because it can be microscopic, in particular in teens. And then excision as opposed to ablation. So I always explain, for the listeners out there, excision, often those with endo, their anatomy, their pelvic anatomy, like their uterus, ovaries, is shifted either to the right or the left or to the back, because these endometriosis implants are pulling the anatomy. So excision is removing, excising. I use scissors, cutting out those implants, which then allows for a restoration of the anatomy. But I think it's part restoration of the anatomy and part removing the inflammatory mediators that's setting these chain cascades of inflammation throughout the body. And I explained excision to someone like that. If my entire fingernail is an implant of endometriosis, ablation is just going to get the white part. Excision is going to get the whole thing. And it's just it's 2 different beasts. You can't even compare them. We have prospective randomized placebo-controlled data to show that excision is better than ablation. Yet 99.9% of doctors, gynecologists, are doing ablation. So a couple of weeks ago, I was, thankfully, I've been now invited to go to DC twice. We did a screening of the second movie that I'm part of, Below the Belt, with Congress in March for Endometriosis Awareness Month. And then we were back in June doing another screening for the release of the movie on PBS, because you can now watch Below the Belt on PBS. That was June 21st. So we were in DC with Congress, and then we met with bipartisan people from both sides of the aisle, plus people for the NIH. And part of what I had said to them, because I think I spent half my not half my time. I spent a lot of time doing advocacy work, raising awareness. And I explained to them, I'm like, OB and GYN should be two different tracks.
Oh, yeah.
GYN should be surgical. OB should be OB. I don't need to know how to manage diabetes in pregnancy. I should be in the ICU learning how to manage a sick patient. I should be working with oncologists and urologists and general surgeons. And someone came up to me after we had this amazing, it was like our first coalition, Endometriosis Coalition, a couple of weeks ago. Parenthetically, we're invited back in September, actually, to continue this whole process. And she's like, oh my gosh, I have never even heard of that concept. That is a brilliant idea. So anyway, so yeah, you're spot on saying that OBs, they don't know how to operate.
Yeah.
They shouldn't be operating. In the same vein, I know how to do, with Dr. Lou, I did a bunch of stress incontinence, but I don't do it a lot. I refer that out.
Yeah.
I do what I do a lot of.
Yeah.
And that's it.
And that's why you're good at it. And it's, and getting great results with this. A phrase I described to patients when I was looking at dealing with endometriosis, that, all, of course, concerned about fertility. And I said, what I'm trying to do is radically conservative surgery. And just because I'll do everything I can to get every little bit of endo I can see. But I'm trying to either preserve fertility or enhance it. And because that's one of the things that they're all concerned about. How is this going to adversely affect? So I understand really completely what you're saying. I noticed that you use the Da Vinci robot in some of your surgeries. I worked with a company called Computer Motion in Santa Barbara, as I mentioned earlier, and we were developing something very similar to Da Vinci. They had patent issues with Intuitive, and ultimately they merged. I was trained on Da Vinci around 2005, 2006, when it was first cleared for GYN use, but I'd been working in the lab with that before, and that was one of the reasons why I was getting on the speakers panel, not because I'd done so much endometriosis surgery, but I'd been working in robotics for a while, and that's why I was on the program traveling with CY or with Harry. I didn't like the robot because it was slower, and particularly I couldn't feel the tissue. And I know that Harry just felt, where he would preach, you can feel the endometriosis. And just using a knife and fork, so to speak, as a grasper and scissors to excise all of this. How do you deal with the lack of tactile sensation?
So I'd like to challenge that thought. So I don't think the wand makes the magician. I don't think the instrument, I think a good surgeon is a good surgeon is a good surgeon. And the reason I started to train, and I've had many discussions with Dr. Rich about this, but the reason I decided to train on the robot initially was, at that point, I felt like I'm way too young in my career. I want to just learn all modalities and let me just know what's out there, and then let me choose what I think is best. And I went into my intuitive training, Da Vinci training, feeling like I can do anything with straight sticks, because I've always been able to. Right. Whether it was suturing the uterine arteries for a hysterectomy, suturing the appendiceal arteries for an appendectomy, like everything was skillfully done. And then I started to train, and I sat down at that platform and I was like, oh my gosh, this is incredible. The 3D high definition and the wristed instrumentation.
Yeah.
And
it's so much fun too.
What?
It was so much fun to use it as well.
Yeah. But even more than that, I was at an academic institution with residents, and residents, like, the camera's always upside down, and that There, when you're doing the laparoscopy, I only have two hands. So then I'm relying on the resident to hold the bowel back or to hold the camera. And inevitably, it's like I have to keep stopping what I'm doing, putting my instruments down, and then reposition what they're doing and reposition the camera. And that goes on 40, 50 times in a case. That's right there, 40, 50, stop, go, stop, go, stop, go. So with Da Vinci, I have access to the camera. I have access to like 3 instruments. I can park an instrument so that like it obviates the need of that training physician holding things. For me, I am so much quicker. The thing with robotics, there is a learning curve of, for me, it was at least 50 cases or 60 cases. Yeah. And just who I am, I didn't do my first patient until I sat on the robot for almost a year training, but that's just who I am. And I am so much more efficient doing robotic surgery. With that being said, if someone's an amazing laparoscopist, do what you do best, what you're trained in. There's amazing laparoscopists who are straight stick, and keep doing what you're doing. I know that for me, robotics has enhanced my ability to see better because I do teens primarily, a lot of. So you see the 3D high definition. I'm seeing those clear vesicles much better. And my surgeries are like boom, 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 boom from an excision standpoint because I don't have to stop and re-hold what the resident isn't holding or my assistant. So I just think it's an amazing technology and an amazing platform. And for me, I've never gone back, but I don't judge anyone if they're a straight stick. And there's plenty of straight stick laparoscopists.
Yeah, I've always felt with having spent a lot of time in the lab with the robot is that endometriosis was really the disease that would benefit from the 3D definition that you're talking about, and basically some cancer surgery in GYN. Yeah. Now the robot can enable us to do things that we physically can't do as human beings because of the angulation and the magnification and the stability, and being able to regulate the strength of the movement, the magnification, right. And so on. Yeah. So it was, to me, I don't do a lot of endometriosis surgery. I don't do a lot of surgery actually now, but most of mine was not endometriosis. And so a hysterectomy I don't need this for a hysterectomy. It's just, and because I looked at Harry's technique and seen him work and just, I could put a stitch in and tie a knot and so on, which, is a more difficult thing for the average gynecologist to do.
Yeah. The interesting thing is I do my surgeries robotically the same way I did them laparoscopically. Mm-hmm. There's no difference in my approach or my technique. I think what happens is when gynecologists start doing different, maybe robotic surgery, they start using instruments they're not familiar with, or they start doing different. I'm like, I do it exactly the same way. It's just with a different platform. So,
getting off the subject of surgery itself, what about medication? Use of medications, of GnRH agonists and antagonists in the treatment of endometriosis? Do you use them at all?
No, I would never take them, and I would never give them to my daughter, ever. Okay.
So what drugs are you referring to?
There's a medication called Oralissa,
okay,
which is a GnRH, a gonadotropin releasing hormone antagonist. And then there's another one that has been used, which I think is off the market now, which was Lupron.
So I'll tell you, because my philosophy is really the inflammatory approach of endometriosis. Okay. So we know, so there's medical management for endo, and then there's surgical management. All medical management is really just treating symptoms rather than cutting out or removing the disease that's pro-inflammatory, that's setting off all these inflammatory mediators. So if someone, birth control is like probably the most well tolerated out of all the medicines, but many patients don't tolerate birth control. But it's like, if you have heavy periods, it may lessen your heaviness of your periods. If you have painful periods, it may lessen it, assuming you can tolerate the side effects. But the problem is those inflammatory mediators are still kicking into high gear, causing fatigue, exhaustion, gut issues, and they're going to continue to potentiate, the issues. The thing is, like, listen, if someone says to me, the thing is, my practice, by the time someone comes to me, they've tried every medical management on the product, on the market, and they're like, didn't like that, didn't like that, didn't like that, had a side effect with that, almost wanted to commit suicide, won't do that, won't do that. They're not even willing to entertain that. By the time they've come to me, they've tried or they've denied everything. There is always a role for medical management. If there's someone who can't have surgery, there are like contraindications to having surgery. But in general, I have found we approach a mind body, clean up the gut, get them into pelvic floor PT. If they have vulvodynia, addressing that. If they have whatever issues they have, if we treat all of those, I think that they do much better than medical management. The side effects of those medical management is putting these patients in a menopausal state.
Right.
So already they're still crummy. So now you're adding hot flashes, weight gain, joint pains, muscle aches, osteopenia, which is weak bones, osteoporosis, which is very weak bones, depression, and suicide is on the package insert for some of these medicines.
Yeah.
But most of my patients have anxiety and depression already. Like, so they're not even the right, and when a lot of my patients have painful, deeper penetration in sex because of the diagnostic delay in being picked up, if I'm not mistaken, unless I haven't checked the package insert in a while, or Alyssa, if you have painful sex, you're supposed to have the higher of the 2 doses of this medicine. But it also says in the package insert, don't take this medicine for more than 6 months.
Yeah.
So in my mind, what's the point in a medicine you can't take for more than 6 months? Listen, if someone's like, I just can't have surgery, my mom just had open, like, bypass, I'm taking care of my mom. Okay, we're going to schedule your surgery in 6 or 8 months. Maybe that's an opportune time for that medicine. But in general, it doesn't make sense to me because the patients are already feeling so crummy and so miserable. And many of them are desirous of fertility. All these medicines prevent fertility in that time frame that they're on the medicine. So I'm not a big fan, and I've had such amazing success treating mind, body, gut, and they just do so much better. And then, excision of endo being the cornerstone of healing for these patients.
Yeah.
In your book, you work with Amy Stein. Is that how you say her name? Yeah. And she's a physical therapist. What does she do?
Yes. So my practice was in Manhattan for about almost like a decade and a half. And I was bi-coastal then, LA and New York. And now I'm, based out of Los Angeles. And Amy Stein is a pelvic floor physical therapist. And when I finally, after 10 years of like saying, I'm going to write the book, am I going to write the book? Am I going to write the book? Am I going to write the book? Yes, I'm finally going to write the book. I met Amy for coffee. Amy and I had collaborated extensively on patients over the prior maybe decade, her doing pelvic floor PT on my patients. And I really saw my patients got better with the pelvic floor PT. So I met her for coffee and I said, Amy, I'm going to write a book on endo. You and I both know that like 99% of our patients have pelvic floor type muscle. I just think it's going to be a much better book if we both write it. And she's like, oh, I don't know. She's like, I've got so much going on. She was the president of IPPS at the time, the International Pelvic Pain Society, or she was about to start her tenure. I can't remember. She was so busy. And I'm like, Amy, it's going to be big. We're going to really make such a difference in patients' lives. Anyways, so then we wrote the book together. And I think it's a much better book from the lens that she offers,
Mm-hmm.
the pelvic floor PT lens. Yeah.
Right.
Quick thought about severity of endometriosis. I hear the comment very frequently is that people are surprised with operating on a patient they are seen to have endometriosis when it wasn't suspected, and it can be even stage 4 without symptoms. And then there are other people that have this tiniest bit, a little pinpoint endometriosis and excruciating, debilitating pain. Is that just because we're not looking hard enough at those patients that just don't seem to have very much, so we're just not recognizing those other areas of endometriosis like you've explained in the teenager?
I think part yes, but even in my hands, I know what endo looks like because that's all I do.
Mm-hmm.
And there is absolutely no correlation between quantity of endo and severity of symptoms, for sure. And that's why I keep going back to the inflammatory effect of endometriosis and the way the nerves upregulate the central nervous system. So I think we have to look at the pathways, and Pam Stratton's work, and I'm blanking on her partner. They were the first to really describe endometriosis lesions and central sensitization and upregulated central nervous system. And it's more the inflammatory effect and the central nervous system's response to the endo that predicts the amount of pain rather than the quantity of the disease. And that's why I'm always working from the mind on down in order to help my patients.
Yeah, it's tremendous.
Yeah.
You mentioned athletics at times, hand-eye coordination as being part of why you ended up being a surgeon. But the unknown thing about you in terms of for probably a lot of the population, a lot of your patients also, is the special comment that we wanted you to make of what is unusual about you, other than all the things we've actually discussed. And it was that you're a triathlete as well. And you did the New York Triathlon in 2015. So the endurance that's necessary for that, along with everything else that you're doing, is just really remarkable. And we could go on for hours talking. I just love talking to you, love hearing what you've done. You are sincerely a breath of fresh air to me. Thank you.
Thank you. I'm so honored to be here. And thank you for really nailing me down, getting me on here. It's something I truly did want to do. It was the leading up, the last year has been so amazingly rewarding, remarkable, but so busy with the lead up to the PBS launch of this movie that I had been part of for over about a decade. And then just this year was such a busy year with the lead up to that. So I appreciate your patience in getting me here.
It's Kerin that we help. We have to thank for that, frankly.
We loved the movie, by the way, a documentary or movie. I was wanting more out of it though. I was I loved following the 4 patients and the stories, but I was so excited you were coming on, because after watching that, I just wanted to know more, about everything you were doing and everything that can be done to help patients. So, yeah, it was great.
That actually does bring up another point that I hadn't, I'd forgotten is the compensation for doing the surgeries. And one of the things that you talk about in the documentary is that the surgery takes a long time. That ablation, however it's done, is just much quicker than an excision, and the compensation to physicians is just not enough to really have a decent life out of it. And so did you drop insurance contracts?
I've been out of network for quite a while.
Yeah.
And I hope for a day where I can just treat whomever wants to make an appointment. the problem is, and I spoke to this when I met with the bipartisan people who are policymakers in the NIH in June, and I said to them, as part of my part, I said, I was asking this, it was like a roundtable discussion, the first endometriosis coalition, and I was saying to them, okay, so what do you think my reimbursement is if I take insurance? I could do a 2-hour surgery, I could do an 8-hour surgery. What would be included in the surgical fee, according to like the way that they do coding, would be the pre-surgery visit. So in my case, that's 45 minutes of counseling, being there on the day of surgery. Even if their surgery is 4 hours, I'm at the hospital an hour before and 2 hours afterwards. So 6 hours. Then there's a global service fee of 3 months. If the patient feels the need that they are in pain and they need to see me or talk on the phone, or come to my office every day for 3 months, that's included. If they have a yeast infection in that time or a urinary infection, which has nothing to do with surgery, I don't get compensated for that either. The liability of operating on the bladder, the bowels, the ureter, endo is as hard as cancer surgery. When I was in New York, people from Sloan Kettering would send me their patients. They're like, we don't want it. It's so hard.
Yeah.
Okay. And so I posed to like these decision makers. I'm like, what do you think that's worth?
Yeah.
Yeah.
Insurance reimburses $600 and some dollars.
Yeah.
For all of that. So I'm like, I have staff. I give my staff, I pay them well. I have a beautiful office so my patients feel comfortable when they come. I have a billing service. I have malpractice. So then I said to those people at that round table, I'm like, how many surgeries would I have to do at $600 per surgery to even turn a profit? Not even turn a profit, be able to pay my staff rent, malpractice. And they understood. When you say it like that, because people don't understand what's behind it. Whereas an orthopedic surgeon does 6 surgeries a day, a knee surgery, and I'm not saying pay orthopedic surgeons less. No. I'm just saying a knee surgery, there's not the malpractice, there's not the complexity. They're not operating on an aorta or an iliac vessel or the bowel or the ureter. They can do all these surgeries. They're getting probably like 5 times as much per surgery for a half an hour clean out of the knee.
Yeah.
Yeah.
So I hope to challenge the insurance companies to show a multidisciplinary approach, throwing in, pelvic floor PT, because that's not included either. Like there's no good pelvic floor PTs who take insurance. Right. Throwing in like psychology, psychotherapy, pain therapy, throwing in mind, body, movement, yoga, all these integrative gut nutrition. That's out of network also. I want to show, I have like a whole business model, not business to make money, but like to
make it work.
To make it work. I've had it for over a decade. It's called my business plan. It's called Beating Endo. I just need some like organic company to fund it. I want to do a small trial. I know it works. I've been doing this for a long time, but I need a statistician. I need someone to prove that it works, to show insurance companies, then to do a bigger study, then to do a multi-center trial, so that one day doctors will be reimbursed so we can take insurance. Right. It's unfortunate. Trust me, I had surgery by an out-of-network doctor. My older daughter, the same thing. All our PT is out of. I've dropped $150,000 on my care and my daughter's care.
Yeah,
I'm the one feeling it too. I get it. It's a crazy, crazy number.
Yeah,
it's a crazy, crazy number for integrative nutrition, gut health, all of this multimodal approach. It's crazy.
I personally went out of network 15 years ago for exactly those reasons.
Yeah. But what people don't understand, if you go in network to a doctor, they're going to spend 7 minutes with you. If it takes me 6 hours to read the records, I'm spending 6 hours. Right. I spend 1.5 hours to 2 hours on a consult. I have great staff in the office. If my patients are calling, their needs are met on that moment. If they need someone to cry to on the phone for an hour, we have someone in the office to help them. I'm holding their hand on the day of surgery. I'm meditating with them. I'm calling them daily after surgery. My staff is calling them. If they need us to call for 30 days in a row after surgery, we call.
Yeah.
So It's like a whole different Like
Yeah.
we are delivering the care to them. I can't do that. There's not enough staff I could hire. I couldn't even hire this staff if I took $600 for an insurance, a
Absolutely.
surgery.
Yeah.
I'd be a yoga teacher, quite honestly, if that's what I had to do. If I just see 40 patients in a day, I would go open up a fitness center, a mind body center. I love that too, but not to be live in the negative.
Yeah.
Yeah. No, we totally get that. And our office is very similar with the hand holding, and we're a low volume practice. Duncan spends a lot of time with patients. So
our first visit's always an hour, and it's I will see 8 patients in a day, not 40, and the system is broken, and you seem to have a solution at least for endometriosis, and let's hope that this conversation can help you to achieve those goals of resolving this issue and getting physicians paid appropriately so that they can get the right treatment. So again, thank you. Tremendous. Thanks for listening. That was really informative. If you want more information, you can see the link to a short when we discussed endometriosis a few weeks ago.
We've included a link to Kerin Orbuch's Instagram and also a link to her book, Beating Endo: How to Reclaim Your Life from Endometriosis. Thanks again for listening.
You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. See you in the next episode. The Vagina Doctor Podcast. It all starts here.